All right, we're in the home stretch here for a couple last drugs that we're going to talk about, starting with the macrolides. These are protein synthesis inhibitors as well. They are going to inhibit a different subunit, the 50S subunit, rather than 30S is the one we talked about before. But again, remember, that's not terribly important in terms of how they do it. They bind to a different subunit of the bacterial ribosome, but it's again going to get in the way of protein synthesis. So they are generally considered to be bacteriostatic. I should look to make sure your book says. Sometimes when you give them in high doses, they're considered to be bactericidal, but in regular doses, they're considered to be bacteriostatic. So these are drugs that you may be after the macrolides. Pardon me. We're going to talk about chloramphenicol and then the sulfonamides. So the macrolides, erythromycin is probably one you've heard of. There is also azithromycin. There is clarithromycin. These are drugs that are probably familiar. They are similar in spectrum to penicillin, but they don't cause the allergy. So this is a very good substitute for somebody that you might want to give penicillin to, but they have an allergy. Although I must say also that resistance, just like with penicillin, resistance is a pretty serious issue. So just like penicillin, these drugs are safe. They're used for mostly respiratory infections, probably is the most common. They're also used for Campylobacter. They're used for Legionnaire's disease, which is sort of strange. Also for Rickettsia, Mycoplasma, those kinds of things. I remember once there was a mnemonic I learned for remembering what the macrolides were effective against, and it was, or the drug of choice for, I should say, was Legionnaire's camps on my border for Legionella, Campylobacter, Mycoplasma, and Bordetella. They don't have very many side effects. The big side effect with these medications is GI upset, which limits their use in some patients. Also, they also increase gastric emptying from the stomach into the duodenum. So that is something sort of interesting. So they cause gastric distress and motility. They do have some ototoxicity associated with them, and it seems to be transient deafness here, especially with erythromycin, but at pretty high doses. Azithromycin has been associated with irreversible hearing loss as well. There are some issues with the liver, so we might want to be cautious with people with liver disease and these drugs. These drugs tend to accumulate in the liver, and there has been some hepatotoxicity. Sometimes you might see a prolongation of the QT interval with the macrolides as well. I mentioned earlier that the resistance is an issue. There is a newer macrolide, and it starts with a K. What the heck is that one called again? I'm forgetting its name. Oh, it's ketolide. Ketolides are new types of macrolides, and telithromycin is an example of a ketolide. The reason why I'm mentioning this is because they don't really show as much resistance. So bacteria that have become resistant to macrolides seem to still be susceptible to the ketolides. So that's something to know. Another kind of interesting potential effect of the macrolides is the drug seems to concentrate also in macrophages, and it does show some anti-inflammatory effects as well. And that's kind of interesting. It seems to inhibit the pro-inflammatory cytokines. And that seems to be especially effective in respiratory diseases, especially especially cystic fibrosis, because there's kind of a lot of inflammation there. So those are the macrolides. All right, so then we're going to go to the lincosamides, and an example of these are lincomycin and clindamycin. Okay, so the lincosamides have a similar mechanism of action and spectrum to erythromycin. They aren't used that much, but they are used for some infections caused by anaerobic bacteria like B. fragilis. They also are the drug of choice for anaerobic GI infections. One of the big worries with clindamycin is the association with pseudomembranous colitis, which is a really nasty bowel infection. It's a super infection. It's mostly due to an overgrowth of Clostridium difficile. And the reason why we see this is because Clostridium difficile is resistant to clindamycin, and it's not an abnormal inhabitant of the large intestine, but mostly kept in check by all of the other healthy flora. But if you give clindamycin and it wipes out a bunch of flora but doesn't wipe out C. difficile, then we can see this potential for this pretty nasty bowel infection, which is very difficult to eradicate. So that's a big worry with the use of drugs like clindamycin. All right, chloramphenicol. So chloramphenicol is a broad-spectrum antibiotic, very broad spectrum. It's effective against most aerobic and anaerobic bacteria, not against Pseudomonas. Chloramphenicol is not used often because it's toxic. It's reserved for life-threatening illnesses, or infections, I should say, because of its serious life-threatening adverse effects. The main problem is a dose-related bone marrow depression that can cause a pretty good anemia. It can also cause aplastic anemia, not that common. It looks like it is about 1 in 40,000 cases, but that if somebody does get aplastic anemia, it's usually fatal, and you can see there that it can also appear after the drug has been discontinued. Chloramphenicol can be given orally. It penetrates the central cerebral spinal fluid, and it's inactivated in the liver by conjugation. Infants are not supposed to take chloramphenicol because they're not able to eliminate it, essentially, resulting in really high levels in the blood, and that causes a syndrome which is called gray baby syndrome, which is often fatal. So basically, the babies develop abdominal distension, vomiting, cyanosis, low body temperature, decreased respiration, and vasomotor collapse. So we definitely don't want to give chloramphenicol to children. And like I said, it's really not often used because of these toxic side effects. All right, I think this is the last one, and these are the drugs that inhibit some type of folic acid metabolism. So sulfonamides, their mechanism of action is to inhibit the synthesis of folic acid, and essentially, therefore, the synthesis of purines and pyrimidines, so the bacteria cannot manufacture its nucleic acid, right? So it can't grow and it can't divide. Sulfonamides. So again, they're bacteriostatic. They decrease folic acid synthesis, which bacteria need for survival. If you remember, bacteria can't absorb folic acid, but they have to make it from PABA, or just para-aminobenzoic acid, and these drugs get in the way of their ability to do that. So the sulfonamides and trimethoprim are going to inhibit synthesis of folic acid at 2 different sites. So basically, the sulfonamides, they're structurally similar to PABA, if you remember, and then they basically block the ability of the bacteria to incorporate PABA. Trimethoprim prevents the reduction of one type of folate to another. So it's dihydrofolate to tetrahydrofolate. Don't need to remember that. But they do that by inhibiting the enzyme, which is called dihydrofolate reductase. This enzyme is present in humans, but it seems that the drug trimethoprim doesn't like human enzymes as much as it likes to block the enzymes of the bacteria. So these guys are called folate reductase inhibitors, I guess you could say. So the sulfonamides, they are broad spectrum, as I said. They're cheap, they're easy to administer, there is a lot of resistance. These are the sulfa drugs. They're used to treat otitis media, which is an ear infection. They're used for urinary tract infections. They're used for vaginal infections. And I guess that's all we really need to say about them. Let's see if there's anything else that your book has to say about them. Nope, that's about it. So that's just some. I mean, there are other drugs that we haven't talked about, and you can see at the bottom of this chapter in your book on page 158, it says that we didn't talk about the drugs for malaria, TB, leprosy, although I mentioned a couple of things. Worms, parasites, there's a whole bunch of other antifungal agents we're not talking about. We're not talking about antivirals, antiretrovirals, etc. So what I would like you to kind of get out of this conversation is just to have a general idea about what kinds of drugs. In reality, the drugs, depending on what you end up doing professionally, you'll probably get very familiar with the drugs used in that particular type of practice. So they'll get more familiar. But now what I'd like you to do is just kind of know those mechanisms of action, general organization of a couple of these drugs, where they target, how they inhibit the bacteria, and just a little bit about their spectrum and that kind of thing. All right, I'm going to come back with one more video about when to choose topical anti-infectives and some potential options around that. And then our final video will be a very brief look at cancer and medications for cancer. A very, very, very brief look at that. So I'll see ya in a little bit.